Good day, ladies and gentlemen. My name is Dr. John McDonough. I'm Professor and Director of Anesthesiology Nursing at the University of North Florida here in Jacksonville. I'm also Director of all doctoral programs in nursing as well at the School of Nursing at UNF. We're here today to talk primarily about the anesthesiology nursing program and what you can expect should you be accepted, what the process is, a little bit about the history of anesthesiology nursing, and we're going to start off with a little bit about what our university is in terms of the State University System of Florida. UNF is one of the major constituent institutions of the SUS, and we started off in the 1960s, and we have grown now to the point where we have about 18,000 students, over 80 master's and doctoral programs. The School of Nursing has a very long history of preparation of advanced practice nurses. We have bachelor's programs in nursing, obviously. We have had master's programs in nursing. We no longer have any master's programs in nursing. Operational, all of our MSN programs and clinical specialties for premier advanced practice nurses have transitioned to the doctor of nursing practice degree. But we do anticipate that we will have some master's programs again in the future. The nursing school is accredited by the CCNE, the Council on Collegiate Nursing Education, which is one of the major accrediting institutions for nursing in the United States, along with the NLN's accrediting commission. The anesthesiology nursing program was first visited by the Council on Accreditation of Nurse Anesthesia Educational Programs. That's the group that accredits anesthesiology nursing programs in 2005. At that time, they had 92 criteria to meet in order to be accredited. We were found to be fully compliant in all 92. We had our most recent accreditation visit in 2019, and at that time, there had been an explosion of the number of accreditation criteria, and we were found to be fully compliant in all 168 standards. That resulted in, later on in the year, us being granted an accreditation period for 10 years, and that is the longest that's permitted by the United States Department of Education. I'd like to talk to you a little bit about the history of anesthesiology nursing, because it's a history that I believe is very colorful, very important, and not understood by a tremendously large number of people. So I think it behooves us, if we're in the business, to understand what our history as a profession was. General anesthesia was first administered not by physicians, actually, but by two dentists from Hartford, Connecticut, Horace Wells and William Morton. And they first did a demonstration of nitrous oxide, which unfortunately, although it is an excellent anesthetic, their demonstration was not very successful. And as a result, Horace Wells did poorly afterwards, eventually committing suicide. He had become an addict to ether and chloroform at the time of his death. His partner, however, William Morton, was a very entrepreneurial kind of a fellow, and he continued to experiment with anesthesia, and with some advice from a chemistry professor at Harvard by the name of Jackson, he attempted to use a more purified form of sulfuric ether than had been used before, and it was remarkably successful. It was done in 1846 at what is now known as the Ether Dome at Massachusetts General Hospital. It was a resounding success. Was published virtually instantly all over the world, and Morton became famous. Now, in reality, everybody thinks Morton was the guy that did it first. A fellow named Crawford Long in rural Georgia actually did it first, administered ether 4 years beforehand. But he just did it in his office with, a few assistants around. Whereas, as you can see, at the Ether Dome at Mass General, there were a tremendous number of people present, and publication ensued. The other thing about Morton, as I said, he was a very entrepreneurial kind of a guy, and what he did was he put red dye into the ether and called it lithion, hoping to get a patent on this substance and then receive some type of royalty for every anesthetic that was administered in the world. It didn't take him very long to do this. If we look back for a second, we see that the demonstration was 16 October in 1846. On 12 November, less than a month later, he received a patent from the U.S. government for the substance called lithion, which was nothing more than ether with red coloring in it. Interestingly enough, the U.S. Patent Commissioner at the time was the son of his good friend, Dr. Jackson. Morton's idea to patent lithion, although he did get the patent, it didn't make him any money, because as you can recall from chemistry lab, once you have smelled ether, you know what ether is, no matter what color it is or in what container it is. So he didn't make any money from it. Shortly thereafter, James Young Simpson, who was an obstetrician in Edinburgh, also experimenting basically on himself and his students and his residents, discovered the general anesthetic effects of chloroform. The problem with chloroform is that it's a very, very rapidly acting agent. It's very insoluble. It reaches out of the circulation to end organs very, very quickly, and as a result of which there's a very, very small margin of error. Ether is a very safe drug. It can be used with very little complication if you pay attention to the patient and take care of the patient. Chloroform, though, can cause morbidity and mortality in the best of hands. And unfortunately, that's what happened to a young lady by the name of Hannah Greener. Almost as unfortunate was the surgeon that operated on her, a gentleman by the name of Thomas Megason. Ms. Greener unfortunately stubbed her toe in her garden and it became infected and she needed to have an unguenectomy, so she called the town surgeon, Thomas Megason, who came out to see her. And she insisted on having chloroform, and she was a rather corpulent young lady. And the good Mr. Megason let her take a couple of whiffs of chloroform and went to take her toenail off and noticed that the blood was kind of blue and that she had stopped moaning for pain and in fact was not phonating at all and in fact was not breathing at all. I'm a big believer in primary source information, so what you see on the slide is the quote taken from the coroner's inquest in Lancashire, Sussex, England. And it basically talked about how Mr. Megason noticed that her face had blanched and he tried to give her some brandy, which I guess is, that's kind of like the full court press in those days for advanced cardiac life support. That and bleeding her, and he bled her, but he didn't get much, he said, a teaspoon or so. That's not too difficult to explain why, no heartbeat, no bleeding. So the unfortunate Ms. Greener was the first death associated with the administration of general anesthesia, and this is probably one of the reasons why, to this day, anesthesiology nursing has really never been a viable profession in any of the Commonwealth countries of Great Britain. In the United States, everybody was using ether. Ether was thought to be a very safe drug. However, chloroform was not, as a result of which only physicians administer general anesthesia in the UK and in the Commonwealth countries. Interestingly enough, in most of the rest of the world, physicians who administer anesthesia are referred to as anesthetists, close to anesthetist but not quite. There is now a move internationally to change their professional designation to anesthesiologist. In fact, the Royal College of Anesthetists of the United Kingdom just changed their name earlier this year, and the Royal College of Anesthetists of Ireland is in the process of doing the same thing. So there's a lot of change going on all over. How do you marginalize a group? Well, you marginalize a group by ignoring their accomplishments, by distorting their accomplishments in what they do. And the other thing is, it's been documented for decades that if you tell a lie long enough and loud enough, eventually it just becomes accepted as the truth. So how did we get involved in this whole Anesthesia Act? It started with the two dentists, and then it developed over to physicians. And so how did we get in the Act? Well, we got in the Act during the Civil War. Catherine Lawrence and several other nurses are recorded to have administered general anesthesia to soldiers on both the Union and the Confederate side during our Civil War. The first nurse who actually limited her practice exclusively to anesthesiology was a Roman Catholic nun by the name of Sister Mary Bernard in Erie, Pennsylvania. The administration of anesthesia was her only duty. She performed no other nursing services at all. She basically just waited in the convent until somebody needed an operation, and she went to the operating room and administered ether to these patients. In America, the mother of anesthesia, which is a term given to Alice McDonough by one of the Mayo brothers. To be perfectly truthful, I don't remember whether it was Will or Charlie Mayo that did it, but Alice became a scientist in a way, as well as a clinician. She was asked to administer anesthesia because the Mayo brothers were doing some excellent surgery and having excellent surgical results, but as was common all over the country at that time, patients were being anesthetized by the lowest ranking member of the medical team. So it could have been an intern or a resident or even a medical student. When in reality, they didn't really care about the patient. They were much more interested in what was going on the other side of that sheet that I refer to as the blood-brain barrier, or on the brain side. They were really much more interested in what the surgeon was doing, and as a result, patients were vomiting and aspirating and dying and stuff. And the Mayo brothers, would sit around and say, we do this great surgery, and yet an unfortunately large number of our patients die. I don't know, why are we having these very junior people administering the anesthesia? Because, the administration of anesthesia isn't really medicine. I think we would all agree that the definition of the practice of medicine is the diagnosis and treatment of human disease and injury. Well, when you're administering an anesthetic, you're really not diagnosing nor treating any specific disease. You're managing symptomatology and sequelae. Well, the Mayo brothers decided that perhaps they needed to look for an alternative to who was providing the anesthesia care to their patients. And they thought, well, gee, since the administration of anesthesia is actually taking care of a patient while we practice medicine on them, maybe we should utilize somebody who knows how to take care of patients. Now, let's see, who do we know who knows how to take care of patients? Hey, how about nurses? So they asked Alice if she was willing to learn how to do anesthesia, and she was. She experimented learning how to put babies to sleep by anesthetizing little rabbits with open drop ether and chloroform. And she became sufficiently famous that people from all over the world, both physicians, surgeons, nurses, all of them made the trek to Rochester, Minnesota, to the Mayo Clinic. One of the very important things is that in 1899, Alice was the first nurse ever to write an article published in the medical journal in Northwestern Lancet. She reported 14,000 consecutive cases of ether and chloroform without a single anesthesia-related mortality, which at that time was absolutely unheard of. So Alice McGaw made her mark, and by keeping records and publishing, she documented the success of our profession, and this was used later in at least two major legal actions where people tried to get us out of the business of providing anesthesia. Frank v. South in Kentucky, and the Dagmar Nelson case in California, which you'll learn about later on. So what other than Alice, what other nurses made a big contribution in the field of anesthesiology? Well, one of them was Agatha Hodgins. Agatha was the first president of the American Association of Nurse Anesthetists, and she introduced the concept of gas anesthesia, that is adding nitrous oxide to the carrier gas of oxygen or air into the vaporizer with the ether, when she served with Dr. Kreil in one of the Army Reserve hospitals that had been activated for World War I and deployed in France. Another famous nurse from that period of time was Sophie Gran-Winton. Sophie came from Southern California, and she was hired by the Department of War to administer anesthesia to combat casualties, and she was actually awarded the Croix de Guerre by the République du Français. The Croix de Guerre is roughly equivalent to our Medal of Honor, and is awarded to people who distinguish themselves by heroic action in the face of enemy combat forces. One of the first organized programs to teach the administration of anesthesia to healthcare professionals was at the Lakeside Hospital, developed by Agatha Hodgins. She was the director of the program. The program was 6 months in length. The tuition was $50 at that time. And you have to remember, $50 was a fair amount of money in 1915. And the first graduating class was 11 nurses, 6 physicians, and 2 dentists. So obviously, we are not the new arrivals in this specialty. We, in fact, were the first people to limit our practice and specialize in anesthesia. Alice Hunt practiced anesthesia at Peter Ben Brigham Hospital in Boston, and later was recruited to go to New Haven, Connecticut to join the faculty of Yale Medical School and to organize an anesthesia department at Yale New Haven Medical Center. She did that in 1922. In 1949, she wrote one of the first American authored textbooks on anesthesiology called Anesthesia Principles in Practice. Most American people who were studying anesthesiology would use British textbooks like Wiley Churchill Davidson and texts like that. But Alice Hunt's book was one of the first American books on the subject of anesthesiology. Helen Lamb was the chief nurse anesthetist and program director of the School of Nurse Anesthesia at Barnes Hospital in St. Louis. Ms. Lamb developed the successful anesthesia technique for the first total pneumonectomy done in the United States by a surgeon by the name of Evarts Graham. And at about the same time, a gas physicist by the name of Richard von Fourier had developed one of the first really modern anesthesia delivery machines. Now, he was not a medical person. As I said, he was a gas physicist. And he worked very closely with Ms. Lamb for several years to find out what the machine was supposed to do, how it was supposed to be done, what kind of gases needed to be used, how were they to be regulated, what other types of adjunct equipment need this anesthesia machine to have. And when the machine was first shown at a medical meeting, Dr. Graham, the chest surgeon, was given credit, public credit, for helping von Fourier develop the machine. In fact, it was the nurse anesthetist Helen Lamb who did that work. In fact, there is in the ANA archives in Park Ridge, Illinois, right outside of Chicago, a letter from von Fourier explaining why, said for, quote, obvious reasons, unquote, the credit was to be given to the surgeon for helping that machine come into fruition. Another fairly stellar person in our history was Olive Berger. I knew, that Olive was the chief nurse anesthetist at Johns Hopkins, and I knew that she had faculty status at Johns Hopkins Medical School, and I thought pretty strongly that she had something very important to do with the anesthetic for the Blalock-Tussock operation, the Blue Baby operation, the first operation done on a human heart. And then later on, I saw a puff piece in some medical center, University Medical Center's internal house organ about an anesthesiologist who was about to retire, and why this gentleman was so famous. And it was basically because he said that he had done all the anesthesia for the Blue Baby cases. And I thought, well, that's not what my recollection of the facts of this matter were. And as I said, being a primary source guy, I went to Hopkins and I went into their archives, and I found the edition of the Dome, which is their house organ, and it was in celebration of the 50th anniversary of the first heart operation done on a human. And it talks about the case, and interestingly enough, this was the picture of the second case, and interestingly enough, at the head of the operating table is Olive Berger, the nurse anesthetist that we just talked about, and it said that she did most of the cases for Dr. Blalock. As I said, you ignore, you distort, and that's what happens. In terms of my personal history, my program director was the late Phyllis Roberts. So anybody who trains here is only 2 degrees of separation from the start of the profession, because the second president of the ANA was Gertrude Fife, and Gertrude Fife was Phyllis Roberts' program director. And I was Phyllis's student, so if those who train here are sort of closely related to the start of our specialty. Phyllis was a most unusual lady. She broke no nonsense. And after the World War II, she was in private practice in rural Iowa, and Phyllis was very good with a needle, very good at spinals and caudals and epidurals. And at this time, there were not many physician anesthesiologists. There were a lot of physician anesthetists who were people that had no training in anesthesia. They were usually family doctors. And they would take turns in town, doing anesthesia for their colleagues' patients. So most of them did new regional anesthesia. They did general anesthesia with ether. And some of these old big farmers who would have their hernias done after ether, obviously everybody throws up. And some of these people would have hernial breakdowns of their repair and have to go back and have it done. And, well, Phyllis did all her cases under spinal or herniaplasties. And these people did very well afterwards, and word soon got out that if you didn't want to throw up after your hernia operation, that you go over to Greene County Hospital in Jefferson, Iowa, and you have this nurse lady put something in your back, and you're going to have a good experience. Well, I suspect that probably some of the general practice anesthetists didn't think that was such a good idea because they were losing some business. So they turned Phyllis into the Board of Medicine in Iowa for practicing medicine without a license, filed a complaint. And the Board of Medicine sent her a summons to appear, and she elected not to. She said, I have nothing to do with medicine. I'm licensed by the Board of Nursing, and you guys can scratch your head because I'm not coming to see you. Instead, what she did was she went to see the Attorney General of the state of Iowa and said, I want a written ruling as to whether or not nurses can or cannot administer regional anesthesia. So the Attorney General looked at all the laws and talked about anesthesia, didn't make any differentiation between general anesthesia and regional anesthesia. So the Iowa Attorney General in 1947 issued a written opinion saying that it was perfectly permissible for nurses to administer regional anesthesia to patients in Iowa. As far as I'm aware, that was the first time there was any written legal documentation about nurses being permitted to administer regional anesthesia to patients, and that's one of the great legacies that Phyllis left the profession. One of the other legacies is she was actually the first nurse to ever write a book on regional anesthesia techniques. It was called Regional Blocks, a manual for nurse anesthetists. And just to show you, what the inflation has done to healthcare book prices, it originally sold in the late 1970s for $11.75. I suspect your books are a lot more expensive now. So where are we in terms of our regulatory status? Under federal rules, Medicare Part B says that we are paid exactly like physician anesthesiologists are paid. We're paid the same amount. There is no requirement for any physician involvement in our cases. Under Part B, we are referred to as what is known as an LIP, a licensed independent provider. There is a Part A supervision under the Medicare participation requirements called the COP, Conditions of Participation. However, each state is entitled to opt out of that federal supervision requirement they choose to do so, and as a result, 17 states have done that under the Medicare Part A opt-out rules. There are 23 states out of the 50 that require some type of physician involvement in nurse-administered anesthesia. Now that can be either collaboration, supervision, medical direction. However, it's worthy to note that none of these states require that physician be an anesthesiologist. Frequently, it's either the president of the medical staff and the chief of surgery or the operating surgeon, but it doesn't have to be an anesthesiologist. 27 states, plus the District of Columbia, have totally independent practice for nurse anesthetists. So we're putting out about 2,000 nurse anesthetists a year now. We have about 2,000 approved clinical sites. Our membership in the Our National Association is a little bit over 50,000. You may say, well, gee, 2,000 people a year, that's a lot. Why are we educating so many people? Well, the answer can be found here on this graph. If you look at the numbers, you can see that 21, 36, 40, 48% of the CRNAs in the country are currently within 15 years of retirement. And nobody's going to let an operating room lie fallow. It's a moneymaker for hospitals. So there's going to be somebody at the head of the operating table. There's no two ways about that. And if we're not there, then somebody else is going to be there, and we're not going to like who that somebody else is. So we have to make people that are capable of taking care of patients. That, coupled with the fact that with our aging population, the post-war baby boomers are now turning into gomers and needing to have their hips fixed and their heart fixed and all that sort of stuff. So the number of cases is obviously going to grow over the next couple of years. Gender-wise, we are a little bit more equitably balanced than other specialties in nursing. Currently, of the CRNA population in the United States, 49% are male and 51% are female. Can you make a living doing this? Absolutely you can. However, if you're in this for the money, do yourself a favor. Go get a real job, okay? It's not worth the time, effort, energy, blood, sweat, tears that you're going to put in this program to make the kind of money that you're going to make as a beginning nurse anesthetist. If you want to make a lot of money, go get an MBA, get a JD, start a company, become a CEO. They make lots more money than people who provide service to other people. So if you're looking at an ROI here, a return on investment, that's probably not what you ought to be doing. You need to be doing this because you want to do anesthesia. And that's got to be the main motivation for you at any time. Program history, the letter of intent to start a program was filed by UNF in 2004. They did a search, they hired a founding professor and director. We had an associate program director. We started looking for clinical sites. We started off with UF Chance Jacksonville, the Naval Hospital here in Jacksonville, St. Vincent's, and additional sites were planned to be added later, and they were. We've continued our accreditation through, and as I said, we got our last 10-year accreditation last year. Regarding the design of the anesthesiology nursing program, here, this is a university-based program. It is not a hospital-based program. It's not a freestanding program. What do I mean by that? Well, anesthesiology nursing for a very long time was like nursing education was 50 years ago. Most RNs graduated from 3-year hospital-based diploma granting programs, and nurse anesthetists graduated from hospital-based certificate granting nurse anesthesia programs. As nursing education moved out of the hospital and into universities to become an academic discipline, eventually that happened to nurse anesthesia as well, except it happened much later. It happened in the mid-1980s. As a result of which, there were no nurse anesthesia practitioners who had the educational qualifications, doctorates, for instance, to have a university faculty appointment. So what most programs did is the hospital-based freestanding programs made an affiliation with an academic institution to grant their graduates a Master of Science degree, either in nursing or some other health science. So frequently the person who directed the certificate program at the hospital was also the chief nurse anesthetist at the hospital. So that person's job was to get the schedule done, treat them and street them in and out. And sometimes class was based upon how busy the operating schedule was. Well, we're not like that. My job is not to run anybody's operating schedule. My job is to see to it that students at the University of North Florida's anesthesiology nursing program are provided with the proper environment and skills to be able to learn how to be a specialist in anesthesiology. I'm not here to produce revenue. I'm not here to take care of patients. Now, do I take care of patients? Of course I do. We have a very strong rule in our department, and that is if you don't do it, you don't teach it. So everybody has clinical privileges and practice in the clinical area with our students, and that includes me. I do my clinical at Tampa General Hospital for lots of reasons, which we'll go into later. Any hospital program is different than a university-based program. And that university-based program is basically a community of scholars and learners. We all learn from each other. I had a student a couple of years ago who was a nurse practitioner, a graduate of Georgetown University in Washington with a specialty in neonatology. Now, do you think I'm going to tell this guy anything about examining a newborn that he doesn't already know? The answer is no. He could probably teach me about stuff, and I would expect him to do that, and in fact he did. We all come here with skills. We're all licensed professionals, so it's not uncommon for faculty to learn from students. Hopefully not as much as students learn from faculty, but nonetheless it is in fact a two-way street. This is a full-time only option. There is no part-time option. The class that you start with will be the class that you graduate with. It's a lockstep curriculum. Everybody takes all the same courses at all the same time. You can't say, for instance, oh, I'm like so stressed, I think I'm going to take a semester off. You take a semester off, you take the rest of your career off, because we've got other people coming down the line. Spaces have to be filled. There's only a certain number of clinical spaces, so everybody stays together. Now, that being said, if there's some reason for you to be out of school, you get hit by a truck or some other disaster occurs, we can always make arrangements. But it's not an elective thing. It's something that has to occur. Why is anesthesiology taught here? If you believe that anesthesiology is the practice of medicine, you might say, I don't understand why this is being taught in a nursing school. Well, I would point out that many professions have overlapping roles. If I walk into an office and take a patient's blood pressure, I'm practicing nursing, obviously. I'm a nurse. If Dr. Mary Smith, the physician, comes in after me and does exactly the same thing, takes the patient's blood pressure. We both did the same thing, so does that mean that Dr. Smith is practicing nursing? No, Dr. Smith is practicing medicine because she's a physician. The issue is not the task that you are performing, the issue is the philosophical basis behind that task and what you do with the information that you have obtained. So I would say that if a physician administers anesthesia, it's the practice of medicine because it's being done by a physician. However, when the anesthesia administration is done by a nurse, a properly trained nurse anesthetist, it is the practice of nursing, period. End of discussion. That's all there is to that. Well, so what can CRNAs do for work? Where can you practice? Well, you could, if you wish, work for a physician anesthesiologist on an anesthesia care team. You could work for a surgeon. You can be an employee of a surgeon. You can be an employee of a hospital. You can be an employee of a university. You can be in totally private practice, bill for service yourself, open a store, John's Anesthesia Company, and offer your services to hospitals and other providers who require anesthesia, surgeons, podiatrists, dentists. Or you can be military officers. Unlike Sophie Gran-Winton and Agatha Hodgins, who worked for the Department of War, but were not in fact members of the military. Nurses were contracted civilians at that time. CRNAs are commissionable in all 4 uniformed services of the United States that utilizes anesthesiology service, that being the United States Army, Air Force, Navy, and the U.S. Public Health Service. So we obviously have 2 very divergent opinions about what is the administration of anesthesia in terms of where does it fall, in terms of which profession. Now, our illustrious colleagues at the American Society of Anesthesiologists say, and I quote, that the administration of anesthesia is the practice of medicine and should be performed by or under the medical direction of an anesthesiologist. That's their opinion, and they can certainly have whatever opinion they wish. The American Association of Nurse Anesthetists, however, says that when anesthesia is administered by a nurse anesthetist, it is recognized as a practice of nursing. So what we have here is what the philosophers or the logicians would say is a diametrically opposed proposition. You both can't be right. So how do you decide what position is right? Well, obviously, if we're talking about potential changes in practice, for instance, you might want to look at the evidence. Well, that's what you're trying to do when you try and determine the rectitude of a philosophical position or a statement of fact. You look at the evidence. It's what courts do. The evidence is put before an impartial finder of fact, which is either a judge in some cases or a jury, and they decide what's right and what's wrong and what's true and what's false. Has this ever been done about this particular question about anesthesia? The answer is yes, and it was done a long time ago. I would refer you to the Federal Register from the year 2001, January 18. And in the final rulemaking, they said, and I quote, "We have found no compelling scientific evidence that physician supervision requirement for CRNAs leads to better outcome." And, I quote again, "We cannot agree that anesthesia administration is a practice of medicine and therefore can only be done after medical school training." So that question has been answered. The administration of anesthesia is not the practice of medicine, especially when it is done by a nurse anesthetist. This fact is one of the foundations upon which this program is built and one of the principles by which it operates. I would venture to say that if you personally believe that the administration of anesthesia is the practice of medicine, and when done by a CRNA it is a delegated medical function, this program is probably not a good fit for you. What are the philosophical premises upon which this program is based? Well, number one, this is a doctoral program. You're going to be in graduate school. This is not undergraduate studies. This is not a place where you come in, the professors come in, they vomit information in front of you, you lap it up and vomit it back on the test. That's not how this works, okay? How it works is it's functionally different from undergraduate studies in that basically your knowledge base is going to be found in readings and in your clinical experiences. Class time is not meant for the sage on the stage. We're not out there putting forth great pearls of wisdom before you. We're there to help you demonstrate and learn critical thinking. We're there to help you with problem-solving exercises, to look at things from different angles, to discuss, to amplify the concepts that you've learned, and to find ways in which they apply in the real world. The half-life of technology in our business, obviously, is very short in healthcare. So we like to use techno-intensive methods. I'm susceptible to paper cuts, so I don't want anybody turning in any papers to me. Everything is electron moving now, not paper moving. We are all trustworthy, students and faculty both. The student will not lie, cheat, steal, or tolerate those who do. Simple, period. End of quotation. Students are competitive with each other, only in other programs, not here. Here they are supportive of one another, okay? We're not looking for somebody to be better than the guy next to them. We're looking for both of those people to be excellent, okay? So we don't leave any bodies on the battlefield here. If somebody flunks out of this program, the most unhappy person is going to be the person that flunks out. The next unhappy people are going to be the people that let that happen to their classmate, okay? We support each other, we help each other. You are good enough to graduate from this program because you were good enough to be accepted, if you wanted enough. This is one of the hardest things that you're ever going to do. And you need to understand that right from the start. And if that's not your mindset, you should probably be somewhere else, okay? This is a place where we help everybody succeed, we support everybody. The desired outcome, obviously, is we expect our graduates to be competent in the administration of all types of anesthesia to all types of patients for all types of surgeries. You need to be a competent evaluator of research. This is not a research doctoral program. It's not a PhD or a DNSC or an EDD. So we don't expect you to generate new knowledge. What we expect you to do is to be able to critically evaluate the evidence and promote change in practice based on what the best evidence shows should be used to solve your particular clinical problem. So you need to evaluate research and you need to be able to change practice. And because of whatever your doctoral project is, you're going to have a special expertise in some specific area upon which your doctoral program, your doctoral project, was based. Unlike many programs, we have an international presence here. This slide shows a couple of people lecturing. I'm lecturing at a conference in Berlin. Dr. Cameron Cushenberry is lecturing at our affiliate institution in Salzburg. Center bottom is Mr. Patrick Ramsey, who happens to be my personal family CRNA, is lecturing in Salzburg as well. And lower left is the late Dr. Mark Welliver, one of our former faculty, lecturing at the International Federation of Nurse Anesthetists. We not only lecture at anesthesia meetings, we also lecture at pain conferences. This is me in Stuttgart in 2018 at the German pain conference. Our international sites are in Salzburg, Austria, Ludwigsburg, Germany, Göteborg, Sweden, and Amsterdam, the Netherlands. In Salzburg, we rotate at the Universitätsklinik für Pharmazeutische Medizinische Universität in Salzburg under the direction of Professor Dr. Peter Gerner, who's an anesthesiologist who actually trained at Brigham and Women's in Boston, was on faculty at Harvard before taking the job back in Salzburg, as he was, in fact, a medical school graduate in Austria. PMU is about a 1,200-bed facility, provides all types of surgical and anesthesia specialties to their patients. Basically what happens is students have the option of, assuming that they're doing well in school, have the option of rotating to one of our international sites for 2 weeks during a specified period. And we have faculty from all of these sites, as well as students from these sites, rotate through our program for a 2-week period. And this is done in lieu of your course in global healthcare and culture, which we will talk about a little bit later. In Ludwigsburg, Germany, the clinic in Ludwigsburg of the RKH, Dr. Krankenhaus Holding Academy, is again, it's about a 1,200-bed hospital. This is a little bit unusual compared to how we do things in the United States, because at this hospital, it is the Department of Anesthesiology, Intensive Care, Pain Management, and Emergency Medicine. So the anesthesia people take care of a lot of stuff in this medical center. and you will be exposed to all of those areas should you choose to rotate there. This site is directed jointly by Tilman Müller-Wulff, who we will talk about a little later, is one of our faculty, and the on-site professor there is Camp Professor Dr. Götz Geltner, who's in charge of the Department of Anesthesiology and everything else that they have in that facility. The University of Göteborg in Germany has the Sahlgrenska University Hospital. This is about a 1,300-bed facility in Göteborg. Dr. Peter Gildenstahl is our guy there, and we send students there, and they send students here. We'll talk about Dr. Gildenstahl and his work in just a moment. The Academisch Medisches Zentrum der Universiteit Amsterdam is a place right in downtown Amsterdam. Again, this is a 1,300-bed teaching facility where they do anesthesia, pain management, as well as intensive care. And you'll be able to rotate through these operating rooms as well if you choose to rotate at this facility. The key individuals in terms of the operation of this program, first of all, is the Dean of the College of Health, Dr. Kurt Laux. Dr. Laux is a sports physiologist by trade. He came to us from the University of Southern Illinois, and he was the Dean of the College of Health there, but that College of Health did not have a nursing school, so this was the first time he's ever actually had an opportunity to work with an academic nursing unit, and I think we are both mutually pleased with the result. He's our first non-nurse Dean of the College of Health, and he's doing a fantastic job in terms of running the college and supporting our program here. Dr. Lee Laura has just stepped down as the director of the School of Nursing. Lee was the director for about 17 years, and she is an advanced practice nurse. She's a nurse practitioner, graduated from George Mason with a PhD, and her master's in geriatric nurse practice was from Marymount in Washington. And she was a crucial key figure to helping this program get off the ground. Being an advanced practice nurse herself, she understood why we need to take so much physiology, why we need to take so much pharmacology, and why we had to do so much clinical time compared to some other specialties. So she just stepped down. She's still on faculty. She's going to be teaching nursing. And our new interim director of the School of Nursing is Dr. Cindy Cummings. I've worked with Dr. Cummings for many years now. All of her undergraduate and graduate education until the doctoral level was done at the University of Maryland, and her doctorate is from UNF. Some of my background is shown here. As you can see, I'm originally one of those dirty old associate degree graduates. So if we have any other two-year grads out there, hey, you know, there's a future. Keep it up. I went on for my BSN at St. Anselm College in Manchester, New Hampshire. Now, the hiatus between those two was not very long. I graduated from Greenfield Community College on Friday, and I started as a full-time BSN student at St. A's the subsequent Monday. I got my CRNA from a hospital-based certificate granting program at the VA Medical Center in Des Moines, Iowa. I got my first master's degree in adult teaching and learning, a Master of Science from Drake University. I got my first doctorate from Drake University in psychotherapy. I did that because I was seeing a lot of pain patients at that time. And actually, when I was in private practice in Iowa, about a third of the dollars I brought into the practice was from pain management as opposed to anesthesia delivery. And it became very clear to me that a lot of the patients that were being sent to me for pain management really need to have psychotherapy, did not need to have needles stuck in them. But it was very difficult to find a provider for mental health services that wanted to deal with pain patients because they're very difficult. As it turned out, Drake had a very highly regarded program in psychotherapy, and I decided that since I was right down the street from my hospital, I did that. And so I could do both the psychological evaluation and the physical evaluation of patients who were sent to me for pain consults. I got another Master of Science in Nursing at the University of Tennessee, Memphis. I have a Certificate of Advanced Graduate Specialization from SUNY, State University of New York at Stony Brook, as a family nurse practitioner. I'm an FNP as well as a nurse anesthetist. And my last doctorate I got when I was 65. It's a Doctor Habilitatis degree from the Medical University of Salzburg in the science of anesthesiology. Now you may say to yourself, you've been listening to me for a while, this kind of doesn't sound like one of my nursing professors I've had before. I wonder why is that? And the answer is fairly simple. 30 years in the Army, better people than you have tried to kill me and failed. So, that which does not kill you will make you strong. So, people always worry about Army colonels, but as you may know, there is another type of a person who is even more cantankerous than an Army colonel. Who might that be, one would say? And the answer is, yeah, there certainly is. And historically, from novels or television or movies, you would say that it's a sea captain. I happen to be one of those as well. I'm a United States Coast Guard licensed master of vessels, motors, sail, and steam. So if you really give me a hard time, I can technically make you walk the plank if I get you out past 3 miles. Just to show you, the bow tie is not a recent professorial affectation. Okay, I've worn bow ties all my life. The picture on the left is me asking Santa Claus at Macy's in Herald Square, 7th Avenue and 34th Street, New York City, to give me an admission letter to nurse anesthesia school. I eventually got that letter, and the picture on the right is my first day as a student. This is my ID picture for nurse anesthesia school. As you can see, bow ties in both. The associate director of the nurse anesthesia program is Dr. Ryan Shores. Ryan, again, is a 2-year associate degree graduate. His bachelor's is from the University of Florida. His Master of Science in nurse anesthesia nursing is from FIU, and he has his DNP from the University of North Florida. Dr. Kathy Fowler is she's an assistant professor, and also she's the coordinator of clinical education. She has a BSN from Bowling Green State University. University of Cincinnati was her master's program in nurse anesthesia. She has a certificate from King's College in London, and she has her DNP from UNF. Dr. Jonathan Pavolate is an instructor in anesthesiology nursing. He's our big techno guy. He has a BSN from Florida National University. He went through the anesthesiology nursing program there. He got his DNP at the University of Florida, and he is also a Master Burrito Ambassador for Chipotle Foods. If you call him, you're going to hear that on his voicemail, and it's on his signature block. He is very proud of that. I'm not exactly sure how it is that you get to be one of those people, but when he walks into Chipotle, everybody stops what they're doing and makes his food. So I don't know how one gets that, but he has it and he likes it. The picture at the bottom of Jonathan I put in because when Jonathan was a student at FIU, he was the first nurse ever to lecture to the anesthesiology department at the Katholische Universiteit Leuven in Belgium. He gave a lecture to the physicians on high velocity penetrating trauma to the chest. The University of Leuven, by the way, was established in 1422. It's been around for a long time. Dr. Bill Self is an assistant professor of anesthesiology nursing. He too is an associate degree graduate. He got his BSN from the University of Central Florida, nurse anesthesia master's in nursing at FIU, and he got his DNP here at UNF. He'll be teaching you research methods and evidence-based practice. Dr. Deborah Harmon O'Connor is an assistant professor. She got her BSN from FIU. She has a Master of Arts in Teaching from Jacksonville University. She has a Master of Science in Health Sciences from UNF. She has a Master's in Nursing Anesthesiology from FIU, and she has a Doctor of Nursing Practice from UNF. Obviously, Dr. Harmon O'Connor enjoys going to school. Daniel Miller is an instructor of anesthesiology nursing. He is our simulation guru. He has been really, really crucially important in the development of our new SimLab and the scenario that you will be utilizing there. He got his BSN from Florida State University, his master's from UNF in anesthesiology nursing, and he's currently a DNP student at the University of North Florida. Dr. Adam Boyd is an assistant professor. He graduated from UF as well, and he got his first master's in nursing at Emory University as an acute care nurse practitioner. He basically ran the cardiothoracic ICU at the VA. He got his, went back to graduate school and got his master's in anesthesiology nursing at FIU, and he has a doctor of health administration from the University of Mississippi. Dr. Jane McCarthy is a professor of anesthesiology nursing. She's one of those 3-year hospital diploma grads from Massachusetts General Hospital in Boston. She went to the certificate granting program at Fairfax Hospital in Virginia. Later on, she got her BSN at Loretta Heights College in Colorado. She has an MSN from the University of Tennessee and a PhD in pulmonary physiology from the Uniformed Services, University of the Health Sciences. After nursing school, Jane went into the Army, served in Vietnam in one of the big receiving hospitals there, came back, transferred from the Army into the United States Public Health Service, and she retired as an 06 captain in the public health service. She was the founding professor and chair of the nurse anesthesia program at the Uniformed Services University of Health Sciences. She was also a regulatory scientist for the FDA, serving both in CDER, the Center for Drug Research and Evaluation, and in the respiratory and anesthesiology device section, evaluating research on anesthesia devices for respiratory therapy and for anesthesia that we're seeking to have approval to be marketed in the United States. Dr. Michelle McDonough is an assistant professor. She will be teaching pharmacotherapeutics. She's a family nurse practitioner, and she teaches both the FNP students and the psychiatric mental health nurse practitioner students and the nurse anesthesiology students in terms of the basic pharmacotherapeutics course. Graduation from this program will provide you with prescriptive authority in Florida based on the fact that all nursing specialty students at the doctoral level all take the same health assessment and diagnostics course. They take the same pathophysiology course, and they take the same course on pharmacotherapeutics, and those are the three courses that are required to get you prescriptive authority in this state. Some of our community instructors, Dr. Nick Callanish, is a BSN grad. He was in the Navy at the time from Point Loma College in California. He graduated from the Navy's nurse anesthesia program. He has a master's from George Washington University, and his doctor of nursing practice is from FIU. In terms of overseas faculty, he had Dr. Tidman Mueller-Wolf is an instructor in anesthesiology nursing. He's also the leader of the RKH Academy. He got his RN from the 3-year hospital diploma program at the Krankenpflegeschule at the Kreiskrankenhaus in Alsfeld, Germany. His Bachelor of Science is from the Fachhochschule in Magdeburg. He got his CRNA from the University Hospital in Marburg, and he has his master's degree from the Technische Universität Kaiserslautern, and he's a DNP student here. Herr Universitätsprofessor Dr. Jürgen Osterbrink is the founding professor and dean of the Institut für Pflegewissenschaft und Praxis, the Institute for Nursing Science and Practice at PMU, Paracelsus Medizinische Universität in Salzburg, and he also has an appointment as a full professor here. He got his RN diploma at St. Francis Hospital in Münster. He got his registered nurse anesthetist. Technically, they can't be CRNAs because to be a CRNA, you have to take the American boards. So we just call them RNAs or GRNAs, graduate registered nurse anesthetists. He got that at the Uniklinik in Münster. He has a Master of Nursing from the University of Glasgow in the United Kingdom. He has a PhD from the University of Leuven in Belgium, and he has a DHL honoris causa from UNF. Dr. Peter Gildenstahl is an associate professor at the University of Göteborg and at UNF. His bachelor's, his master's, and his PhD all come from the University of Örebro in Sweden. Interestingly enough, his PhD is in medical science and surgery. Even though he's not a physician, he's a nurse anesthetist, but that's how their doctoral programs work. So it's a medical science PhD. His specialty, by the way, is looking at the transfer of volatile anesthesia agents across the blood-brain barrier and how that disrupts cognition in patients, specifically older patients. Dr. Haben Philip Lurk was an associate professor at the University of Amsterdam. He has now moved to Boston. He's on Harvard's faculty at Brigham and Women's Hospital. He holds an associate professor appointment here at UNF. He got his MD from the Leopold Franz Universität in Innsbruck, Austria. He has a Master of Science from the Cardiff University in Wales in pain management. His Dr. Habilitatus, which is like the degree that I have, is from the Leopold Franz Universität in Innsbruck. He has a PhD from the University of Amsterdam, and he did a clinical research fellowship at the Medical University of Wisconsin. Dr. Lurk's major specialty is the influence of local anesthetic drugs in producing toxic reactions in neural tissue, and he's actually quite famous. One of the people that keeps us all going in the right direction, especially you guys, is Megan Nimchek. Megan has an MPH, Master of Public Health from UNF. She got her bachelor's degree from the University of Florida, and she's currently a Doctor of Public Health student at USF, and she is the Assistant Director for Anesthesiology Nursing Student Success. So she'll be the person helping shepherd you through the program. The newest member of our team is Ms. Aletta Hayes. She's the Administrative Secretary. She just joined us as of 1 July. We're very happy to have her. She was an Administrative Secretary for other areas in the School of Nursing. Well, now she's 100% with nurse anesthesia. So one of the characteristics of this program, it's partially front-loaded. What does that mean? There are programs that are integrated, and there are programs that are basically phase 1, phase 2. What the phase 1, phase 2 program is your phase 1 for whatever it is, a year and a half or whatever. You're always in the classroom. You never get into the clinical area. Phase 2, the second half of your education, is all in the clinical area, basically. Integrated programs have courses in clinical virtually every semester. We're front-loaded in that the majority of your didactic courses come earlier in the 9 semesters of the program. You will not have clinical until starting your 3rd semester, which will be an orientation towards clinical practice in anesthesiology. Attendance is mandatory at all activities. You will be where you're supposed to be, when you're supposed to be there. If you've taken any courses that are in the curriculum at UNF, they do not have to be repeated. Schedules change. And they may differ from those that are published. So if you are merely flexible, you're much too rigid. You're going to have to be fluid. Laptop and high-speed ISP service is required. As I said, we move electrons, not paper. The annual National Board for Certification and Recertification of Nurse Anesthetists administers something called the C, the self-evaluation examination. You will take it in your 2nd year and your 3rd year. This will be used for you to compare yourself with all other graduates across the country within your year group, broken down within specialty areas of anesthesiology nursing. Anesthesia meetings are strongly encouraged. We usually have our 3rd years very highly represented at the ANA National Congress, the annual Congress, which moves around the country. The Florida Association of Nurse Anesthetists has 2 programs in the state as well, which are usually well attended by those more junior in the program. You will conduct a doctoral project, the results of which will be reported. Our clinical sites currently are locally are UF Health Medical Center here in Jacksonville, St. Vincent's Medical Center in Jacksonville, both the Riverside campus and the Southside campus. The Mayo Clinic, Contura Facial Plastic Surgery Institute. This is Dr. Roberta Garcia's practice. This is a nurse anesthesia only practice. There are no anesthesiologists at that practice. Memorial Hospital in Jacksonville, Orange Park Medical Center, South Point Surgery Center. We have distance sites in Daytona at Halifax Medical Center, Tampa General Hospital, that's where I do my clinical, so you'll do clinical with me there, Flagler Hospital in St. Augustine, North Florida Regional Medical Center in Gainesville, Ocala Regional Medical Center, Alla Palmer Hospital for Children in Orlando, one of the biggest, best-known pediatric facilities in the United States. They have the world's largest neonatal ICU. I believe it's 110 beds, I think. It's a very big place. Habersham Medical Center in Georgia. It's about an hour and a half drive northeast of Atlanta. This is basically a major community hospital where they do most types of surgeries. This, however, is a nurse-only anesthesia practice. There are no anesthesiologists at that facility. Housing may or may not be provided at the distant clinical sites. That changes from time to time. Additional sites will be added in the future. Students will rotate through virtually all of these sites. Basically, we will decide where you go and when you go. You certainly may express your desires, and we'll take them into consideration as much as possible, but we are the people who make the final assignments. Your class will elect a scheduler, however, who will basically construct a schedule for people to rotate and then present it to faculty for approval. 99 times out of 100 we will approve the schedules as written by the student scheduler. After semester 4, you will not follow the academic calendar. There will be no spring breaks, Christmas breaks, that sort of stuff. People get sick 24/7, 365, including on holidays, so we're going to be in the clinical area at that time. In terms of what your course load is going to look like, first semester is 100% online. You do not have to be in Jacksonville. First semester, which starts in January. The courses you will take are role development in advanced nursing practice. You will take health informatics. You will take public health policy implication for advanced practice. You will take statistical interpretation for advanced practice. That's my course. You'll have me for that. And you'll have advanced pathophysiology. In semester 2, which is when you will actually be in Jacksonville, you'll take principles of epidemiology for advanced practice. You'll take theoretical framework, which is actually the graduate course in nursing theory. You'll take the course in health assessment and diagnostics. What this does is give you the ability to do a complete head-to-toe physical examination on children and adults and come up with a working list of differential diagnoses, which you will then later on in other courses learn how to rule in or rule out your differential diagnosis. And you will take professional aspects of anesthesiology nursing, which tells you about our history the legal format in which we practice, and where we've been, and where we are now, and where we're going in the future. That too is my course. Semester 3, which is the fall semester, you will take general pharmacotherapeutics with all the other advanced practice students. You will take principles of anesthesiology nursing 1, chemistry and physics for anesthesiology nursing 1, pharmacology for anesthesiology nursing 1, research methods for evidence-based practice. You will take anesthesiology practicum 1, which is where you first start going through the simulation lab, and you'll actually go to the hospital that you'll be assigned to for your actual clinical practicum in semester 4, and you will take technology and anesthesiology nursing. In semester 4, you will take advanced bioscience for anesthesiology nursing 1. You will take principles of anesthesiology nursing 2. You will take anesthesia pharm 2. You will take chem and physics for anesthesia 2. And then you will take advanced practice role transition, which is how to transition from the role of an ICU nurse to a nurse specialist, and specifically in anesthesiology. And you will be a nursing practicum for anesthesiology. Semester 5, you'll take a course in regional anesthesia. You will learn, obviously, spinals, caudals, epidurals, plexus blocks, peripheral nerve blocks. We have a couple of brand new beautiful ultrasound machines on which you'll learn, and phantom limbs with structures. You'll take principles 4, which is emergency anesthesia and some trauma. You'll be in anesthesiology practicum 5, and you'll take evidence-based practice 1. You'll have a chance to do plenty of spinals, plenty of epidurals, more so than you can count. In semester 6, you'll take advanced bioscience 2, evidence-based practice 2, and anesthesia practicum again. You'll take principles of anesthesia 4 in semester 7. I teach that course. You will take advanced modalities in pain management. We have a specific 3-credit graduate course in that. You will take anesthesiology nursing practicum 5. You will start working on your doctoral project. If you do not choose to do an international practicum, you will have to take global healthcare and culture. If you don't do the international practicum, then you have to take global healthcare and culture. You have to work on your doctoral project, and the last 2 semesters of a practicum is called residency. Not that there's any difference between a residency and a practicum, but it's just that's the terminology that the CCNE, the Council on Collegiate Nursing Education, prefers to see for the last 2 semesters. In semester 9, your last semester, you will take advanced anesthesiology seminar, which is basically a board preparation course. You'll finish your doctoral project, and you will have your final semester of residency or practicum. Certification exam results, UNF is right at the top with everybody else. In terms of financial matters, tuition fees, the tuition is what the tuition is. It's set every year by the Board of Governors of the university. I believe now, right now, I think Florida residents is probably about 500 and change per credit. There is an additional fee per semester for anesthesiology nursing. Now, working is very strongly discouraged, other than in the first semester when all the courses are virtual. I can't tell you that you can't work. You can do whatever you want, but I can promise you the chances of you being academically successful and working at the same time are virtually nil. So I would recommend highly against that, as I believe it to be incompatible with academic success. The admissions process, how do you get in? Well, you've done most of that stuff already. You apply to the university. Your stuff goes to the graduate school. The graduate school decides whether or not you are eligible to be admitted to the graduate school, and only after all those criteria have been met does your application material come over to the department. At that point, the Anesthesiology Nursing Admissions Committee reviews all the applications that have been referred to us by the graduate school, and we decide to whom we will offer an interview. If you do get invited to an interview, you will be here now, and you will come up one at a time. Now, in the pre-pandemic days, this briefing that I'm giving you now would have been given before every morning session of interviews, about 12 people before every afternoon session, and then the people would individually come up and meet with the admissions committee. Well, obviously we can't do meeting in person now, so what we're going to do is we're going to interview you by video teleconference, whether that's going to be Zoom or WebEx, we haven't figured out yet, but I'm going to let our technical people handle that. However, we need to figure out a way for you to get this briefing, to hear about the program and what we do and what we are and where we've been. And so we decided to make this video and make it available to you to see prior to your actual interview session with the committee. After the interview session, you're done. That's the end of the process. And shortly after the last session, we have 6 sessions. Shortly after the last session, the admissions committee will meet and we will make admissions decisions. Now, what's going to happen in that circumstance is there are 3 possible outcomes. One of which is, we really love you, we want to give you a seat in the program. Will you take it or not? The second option is we really love you, but not quite that much. We love other people more, but we're going to put you on the waiting list, okay? Which means if somebody else can't accept their slot, this happens all the time. People get sick, people have operations, husbands lose their jobs, families get transferred, people get hit by trucks. You never know what's going to happen. I can tell you that every year we take people off the waiting list, okay? And the third is, I'm sorry, there's nothing we can do for you right now. Now, if you get one of those decisions, we're perfectly happy to tell you what you can do should you choose to reapply in the future to make yourself more competitive in terms of the applicant pool, because we have a very competitive applicant pool. So it's no sin to not be admitted. However, there are people that reapply, and if they're making progress, there is a high likelihood that they will, in fact, be accepted. Additional information can be found in terms of any questions that you might have at this website shown on the slide. This is the disclaimer where the guy talking really fast at the end of the car commercial. Other charges may apply, and we're not going to be responsible. This means basically we can do whatever we want. There's nothing you can do about it. However, keep in mind that we try to treat everybody fairly. We will provide a Google Hangout on the day that you are scheduled for your interview, where you can meet and chat with UNF students and ask them anything you want. And these are not my stooges, okay? I didn't pick them. The faculty didn't pick them. All we do is tell the class president, I want to have X number of third years, X number of second years, X number of first years to be available for each of these sessions. Now, in the past, these people would actually be there live, and they would be the people that you would be talking to while you were waiting for your turn to go up to meet with the admissions committee. Student applicants have reported that has been very valuable to them in terms of getting information, getting a better feel for things, and they were really surprised because I guess there are programs that interview people and they don't let you talk to the students. Applicants who said, you got to talk to some of your students, they're told no. Well, we encourage people to talk to our students. I think you'll find a much better idea for yourself as to what we're about, what the program's about, what the faculty's about, what the students are about, if you get a chance to talk to people who are going to be your peers. Other than that, I think I've tried to hit about all the high points. If you have any other questions, please feel free to mail napadmissions@unf.edu. I do wish you all absolutely the best of luck in your process. I know that you're not going to think this is a tremendous amount of fun to be interviewed, but we try and make it as painless as possible for you, consistent with making what's a really important decision as to who get these seats. So once again, I say good luck and thank you so much for your attention, and I'll be seeing you on television shortly.